So welcome everybody, and a particularly warm welcome to our colleagues who are governors. So Ben Argo, Martin Rose, John Rose are all here. Very pleased to have you join us. We also have members of the press with us today, and 8 of our colleagues have chosen to join us to observe the meeting. So really pleased to see all of you here. This is our second meeting as a group board meeting in common, hence the 44 that Mark just referred to. We are at this time quite a large group of the two boards coming together. And we had our first meeting really very recently to set up all the formal approvals to create the group. And we did the substantial business of the day at that meeting. Hence, this is a much shorter meeting than normal on Teams. But you are very welcome to join us. We do have just one apology, which is from Anne Tutt. And I am going to ask anybody if they have any declarations of interest in relation to today's agenda. No, in which case, Steve, I'm going to ask you to introduce the story from someone who's used our services. So over to you.
Thank you, Chair, and good afternoon, everybody. I'm delighted to say that we're joined by a number of colleagues. So Kerry from the Patient Experience team and a number of other colleagues, Mike Puckey and Annie Langford, Divisional Directors of Nursing at NBT, and Troy Crompton as well, who's also from my Patient Experience team. Just to introduce Stephen and Stephen's story. So Stephen's story reminds us about the importance of personalised and responsive care, and the value of making the small adjustments to improve people's experience when they're in hospital. It also reminds us about the contribution of the team around the patient, and there's a really beautiful moment in Stephen's story where a healthcare support worker offers to cut his hair and cuts his hair for him. It's important that patients are valued as partners in care, and the importance of no decision about me without me. And also the importance of living our values consistently and in every interaction. And sadly, Stephen talks about one particular interaction which didn't live the values and wasn't particularly kind. And also finally, an element around the risk assessment process we now have in all of our hospitals can sometimes be so tight, because we want to be as risk-free as we possibly can, that it doesn't sometimes allow the flexibility to allow our patients to get up and to get moving and to move about. So what you see on your screen is Stephen's background, and we're going to go straight to Stephen now and hear from him and his story. Thank you, Kerry.
I had a hemorrhagic stroke nearly 10 years ago now, and since then I've got involved in all sorts of aspects of working with the hospital and research councils and one thing and another about matters to do with health and social care. But this story happened last year, and I got a very nasty dose of gastric flu, and so did my wife. And my mobility is pretty constrained by the stroke. I'm hemiplegic, partly paralysed down the left side. And to cut a long story short, I fell over in the toilet, and we had to summon the paramedics. Well, they wanted to send me into hospital because I was dehydrated badly. And they got me back on my feet and into the hospital. It was very difficult being on the general ward because they weren't really clued up on what it meant to be looking after a long-term stroke survivor. And I think this is common to other ailments, but a lot of our problems are invisible. So we've got neurological issues. There are things we can do and things we can't do. They're all different. Every stroke's different. I mean, I don't have aphasia because I'm talking to you. I can't talk. But a lot of stroke survivors will have aphasia. They may be mentally absolutely, intellectually absolutely acute, but unable to express it. That hasn't been my problem. My problem is there are physical things I can't do, and people look at me and think, well, he ought to do X, Y, or Z. And little things like I can't sit up in bed without being lifted, because I can't do long sitting with my legs in front of me. So when they say, oh, just sit up, it's not that easy. So in a general ward, I suppose it's not not reasonable to expect people would understand that all stroke survivors will have issues which may be hidden, maybe physiological, maybe cognitive. Anyway, eventually some OTs and physiotherapists did appear, but it took a long time. And then they kept asking me to do things I just can't do. I'd been rushed into hospital, so I didn't have my wheelchair with me. So a simple matter like transferring from the bed onto a chair was beyond me. I didn't have the capacity to deal with the bed I'd been put in. And without help, I couldn't even get out. And without the physio's permission, I wasn't allowed to. So I felt very trapped. Nobody was being ill-intentioned or nasty to me or anything. But assumptions were made. They'll address you as if you're an idiotic 2-year-old, brainless 2-year-old, and start talking very slowly and very loudly in words of one syllable, when actually what you ought to do is have a proper conversation. And please listen to me. Don't talk at me, talk with me. I was, a day or two later, transferred to the stroke ward. And as you can imagine, although I was not an acute stroke patient, they understood my needs as a stroke patient much better. But I still had this problem with the bed. When I'd been in the hospital as an acute stroke patient, the beds had rails up the sides, but they only went halfway down. Now, the new beds that happened since then, it went right down the length of the bed. And for me, the stroke left me with continence problems, which is another of the things you can't see. And for me, transferring onto a chair to go to the toilet is quite a big deal. And if things are a bit desperate, which they are, given the weakness with a hemiplegia, I traditionally have to sit on the side of the bed, swing my legs over, and pee into a bottle. And that way I get through the night without making a mess of myself, the bed, or dangerously transferring in the middle of the night with no shoes and socks on. So I explained this, and they said, oh, well, sorry, but no, there's no such beds available. Or more likely, and they several times said, oh, well, if you're uncomfortable, we'll get you an air mattress. I had to say over and over again, sorry, but that would make things even worse. I wouldn't even be able to turn over with an air mattress. I'd be even more trapped than I am. I'd finally been cleared to transfer onto a wheelchair or onto a chair downstairs in A&E. When I got upstairs to the stroke ward, the rules were all different, and they had and I remember it from my long stay there, they had a whiteboard up, and they wrote on it what I was allowed to do and what I wasn't allowed to do. And until the physio had approved something or another, the nurses wouldn't let me do anything. So I was back to being totally stranded. And it must have been nice to get at least 2 days before I got cleared to do something as simple as sit on a chair. Nobody told me, but it would have been useful to know that I could have my own powered wheelchair brought in, so that I knew how to transfer into that, and I could get across. And if I needed to get to the loo that way and pull myself up and use it, I could do all those things. But until that point, I'd been as helpless as a baby. And that was actually quite demoralizing. The bed, which I understand and found out later could have been sorted out, there were other beds in store. But at night, if I rang the bell, somebody might come and tell me to wait or something. It might take 20 minutes for somebody to come by when I'd wet the bed and myself, which was embarrassing. And most of the nurses were fine about it, but one wasn't. And that did nothing for my morale. It wasn't very sanitary either. And the end of that story then ran, because I asked the doctor, was there anything they could do about it? And the only thing that could be done about it was to put a catheter in to control it. Nobody explained to me that there might be dire consequences of a catheter. And that story was a very odd one anyway, because it involved scanning my bladder to see whether I had retention problems, when I had the opposite, as far as I was concerned myself. And hours and hours passed, and the junior doctor said, yes, put a catheter in. And then that was countermanded by another member of staff, and they started contradicting each other in front of me, which I thought was very unprofessional, not to say very confusing. Nobody at any point said it could cause a problem, so I never knew what the argument was about. But eventually, in the middle of the night, and I was lying on a soaking wet bed by now, a senior member of staff appeared and said we won't do that. And then another one appeared and said we will. And it was done. And I had the catheter in, and I was a lot less embarrassed after that. Nothing was done about the bed, but there we go. But as long as I was helped, I could get out. And I was allowed to have my own wheelchair brought in, which I need help because the bedsides had to be put down. And they kept saying, well, you just put the sides down. Well, you can't when you've only got one arm that works. It's not quite, and you can't sit up. You need to get round in order to sit up, in order to put the sides down. Anyway, with help, I could now get into my own wheelchair. There was a catheter, so I wasn't wetting myself and everybody else all the time. And in a sense, things got a bit better after that. And I was discharged with a catheter and came home. And it wasn't until it was taken out to merge my urinary sphincter was now not working properly, and I'm on a waiting list for surgery to put in an artificial sphincter. I'm doing this out of a feeling that it's important to give feedback, whether that's good or bad. So the first thing I just wanted to say was I'm an incredible enthusiast for healthcare assistants. I can only speak with wonderment about their commitment and how they do what they do for a pittance. And I think they're brilliant and they should be cherished and looked after. It's the human things, and the HTAs were always particularly good at it. Little things like the one that came in on a Saturday afternoon when she wasn't working and cut my hair for me. Can you believe anybody would do that free? And the healthcare assistants had that humanity that matters, that the doctor who told me it wasn't all my fault and I didn't need to feel guilty, that was more therapeutic than any pills he could have given me. It actually took the guilt away from me. I know things are stressed and time's precious and you haven't got it. But actually those moments where you stop and have a human conversation with people about things which may not actually be medical, may not be about a particular treatment, are nevertheless holistically therapeutic. They really, really matter. And it matters to patients, I think, to feel that they're treated as individuals, as responsible human beings with opinions that matter. So listen, recognize that people's psychological needs are more complex than that. And people need to be treated with respect as individuals and with care and with sympathy. And that may be more important than some of the professional stuff that's going on all the time. And actually, if patients are, or certainly in my case, if I felt very demoralized and infantilized occasionally, yes, sometimes happened, that does nothing for me at all. It makes me feel worse. Whereas actually having a conversation where I'm a real part of it and part of a discussion as a meaningful member has quite the opposite effect, I suppose, about stroke patients particularly. We suffer guilt. We think it's all our fault. We think we're now useless and not part of society. Well, mentally, that's terrible stuff, isn't it? And if what you can do is help people understand that they still matter, then that matters enormously and certainly mattered for me. And it's meant that in the years since all that happened, I have done lots and lots of public work. I've got involved in that at a national level. That would never have happened if I hadn't had my stroke. But it matters to me because I feel I'm giving something back. I feel valuable and valued. And my message to you all is, please, treat us as individuals, treat us with care and respect, acting all over the group, do it all the time. And if you haven't got much time, spare a little
for non-medical matters, like just talking to people and listening.
Thank you. So Stephen's powerful testimony and story and experience of care has really helped us think through both learning and feedback. And I'm going to hand over to Kerry now to briefly go through where we've really taken Stephen's experience and learned and progressed. Kerry, over to you.
Thank you, Steve. Hello, everybody. So we've just learned and heard how Stephen's story is a really powerful reminder of the impact of our care decisions and what impact that can have on our patients, and the importance of keeping care truly patient-centred. Placing that in the context of our very busy hospitals, where staff understandably face competing pressures, facilitating the time to talk and listen is vitally important, and it's fundamental to patient experience. Stephen's experience has reinforced with us that it's the small human things, like the reassuring word from a doctor or the compassion of a healthcare assistant, that have a big impact. We have learnt about the impact that recognising and responding to psychological needs has on patient care, and how this is equally as important as clinical care. Patient stories remind us how important listening, connection, and empathy are to the care that we provide. And finally, individualised care really matters. I think Stephen's shown that in his story. And also, stroke affects everyone differently, and there can be assumptions of needs. So personalised care is really essential to make sure that patients feel seen and supported. Just moving on to share some of the actions that we are taking forward from Stephen's story. So these include opportunities to share his story more widely, to highlight patient-centred care in practice. And I think it's really important to highlight that Nida, our stroke practice development nurse, she uses anonymised insights from Stephen's story as part of the training that she delivers amongst new starters. This highlights that whilst the clinical and physiological elements of stroke care are so important, it is recognising the patient as an individual and the human interaction that sets aside high quality care. We're really pleased to say that Stephen has worked in partnership with NIDA to provide a well-attended training session for those staff who are less accustomed to providing care for long-term stroke survivors. Building on the success of last year's event, which was attended by more than 60 colleagues, a further stroke awareness session is taking place in July, and this is part of a wider series of multidisciplinary trust training events. We're actively reaching out to Stephen to see if he would be prepared to come back and help us to continue to deliver this great work. And with the training that we are delivering, the different types of beds available within the trust are highlighted, and explaining to staff how these different beds can benefit our patients with different mobility needs. It's really important that our actions deliver on the learning and the improvements of care that we've highlighted through Stephen's story. And I'd like to now open to any questions or reflections from the board. Thank you.
Thank you, Kerry. Do you want to pop the slide down?
So thank you very much for that very moving and powerful story. And thank you to Steve and Kerry when you were in touch with him for being courageous and generous enough to share his experience with us. Colleagues, any thoughts or reflections that you'd like to express about the story we've heard? Sue?
I just want to thank you, because I think it's very humbling, isn't it, when you listen. My father had a stroke, actually, and it's so interesting listening to him say, you know, my brain is still active, I may not be physically, but don't treat me like an idiot, I can still have a conversation. So I think it's brilliant that we're utilising feedback from patients. It makes it very, very real. The thing that really struck me was around this issue around consent to have procedures done. the whole issue with the catheter about and people discussing it in front of him. And I wondered if there's something that still could be done about who actually consents, because he makes, ultimately, you would think that he will be given the information from professionals who may not have the same opinion, but ultimately consent should be from him. And I would just wonder if it's a bit of a missed opportunity around this whole discussion around no decision about me without me. And I feel that could be, because it won't just be this, it will be other procedures, ultimately giving the patient information and letting him have that decision. Other than that, I think it's superb, but I just felt that was maybe something we could push a little bit further.
Do you want me to respond, Ingrid? I mean, I think it's a really important point, Sue. And I mean, modern day practice would not use catheters at all, really. And I can imagine the conversation going on between two clinicians saying, let's do it, let's not do it. But I think fundamentally, we should have been having that conversation with Stephen and helping him understand that if we did do it, this could be the implication. So it would help now, but it may be slightly more problematic down the line. So I agree. I think there's something in there about, and it's okay for two people to have a conversation in the room, but actually have it with three people in the room, not with two people, because clearly Stephen felt like he wasn't able to have a part to play in the decision making. So it's a really good point.
Thanks, Steve.
Maria.
Thank you. They're very hard to hear, aren't they, sometimes, patient feedback and how we can respond. And reminds me a little bit of some of the human factors discussions we've had as a board and what gets in the way of people being able to make the time to hear from an incredibly articulate, intelligent patient about what their needs are. And so training is obviously one good way. With staff turnover, this needs an ongoing commitment. I just wondered whether there were other things that we could do as collective trusts around digital flags on our EPR when people come in, the sorts of equipment that we might want to make available to them, other signifiers that actually don't always rely on everyone having every bit of knowledge about some of the complexities that may get, particularly actually with stroke patients. Just wondered if there are any thoughts on that, on what we can change systematically rather than just relying on staff to have had training so that we don't have to hear something like this again.
Yeah, thank you, Maria. And indeed there are. So there are digital flags that we can now apply to our electronic patient record. And indeed, we're using our EPR system in terms of the overall assessment for patients to ensure that we can track mobility and other particular needs that require just some small adjustments in order to be able to ensure that patients get the right level of care and responsive type care. So digital is certainly one of them, training is another. And there's also work we're doing around our values. I mean, there was one particular aspect of Stephen's care which would be more troubling for me, which is about people being left, particularly in beds, and that just that's a big no for me. So I know that there's a professional aspect of that I know that Mike and Annie ensure that their leaders know, particularly all their ward managers and others know, that there are fundamental nursing standards that are incredibly important to us, and that's what we adhere to. And again, we've been doing our own checking around that to ensure that happens, and making sure that call bells are answered and those sorts of things.
Thank you. Deirdre.
Thank you. I guess just to complement what Steve has offered, and of course, we could have heard this story from a number of wards across our city, really. So it's really useful to remember that these issues can crop up in any ward. So the learning is transferable right across the city, and down, of course, to our colleagues in Weston as well. I think just to add to Steve's reference to systems improvements and education and training, I think we've had conversations across our organisations about person-centred care, the value of person-centred care, and as well as education and training and, you know, getting the digital technology right regarding electronic flags, etc. We also have to remember that person-centred care is very much based on a cultural approach. And actually, you know, Steve and I have been having conversations about values-based care, and NBT are implementing a shared decision making very well in terms of perioperative consenting. And across UHBW, we've been using an approach called What Matters to You, which is really targeting what really is important for our patients. And of course, it's different for every patient. So I think between us, there's a huge opportunity for learning in us looking at the shared decision making, and of course, UHBW is NBT learning from some of the stuff we're doing about what matters to you. So great opportunity in here.
Yeah. Agreed. Thank you, Deirdre. Kelvin.
Well, so many messages that kind of I shared in terms of the journey that I had with the hospital, actually. Quite emotional in some respects, because as Stephen said, that just the that human interaction, about the sort of, and maybe not even talking about non-medical stuff, but treating him as a sort of an adult, and talking about normal stuff is kind of would like really like kind of changed his outlook and his perspective on us. So I think that's so important, and that's something that anyone can do, interacting with patients. So of course there's some learning, Steve, around patients being in their bed with you know, and all the rest of it, but I think that just trying to use our values and encouraging our staff when they do get, you know, 30 seconds to ask how someone is in their life, and just ask, you know, a bit about them. I think that could make a massive difference. But I thought it was well said, and we can never be complacent about that. You know, I think it's that we can drive that. It will make a big difference. So thank you for bringing it. It was it's quite an interesting patient story.
Thank you. Steve, are you wanting to come in on that?
Yeah, well, just to conclude, I guess, Ingrid, and just a couple of things to say is that we're clearly sharing this across the system and with our ICB partners, because the first thing that Stephen said was about coming into hospital, and I was curious to think through, are there alternatives to hospital that actually could have cared for him at home, whilst he could have stayed in his own home and received care in the right place. So there do sometimes need to be alternatives to hospital, which I think is important, which is why we're sharing Stephen's story more widely. And then I think the other thing to say is that in terms of healthy hospitals and deconditioning, I know, Deirdre, you and I have had Prof. Brian Dolan down in the last couple of weeks, who is the kind of global expert in how do we stop the deconditioning and value patients' time, and making that time mean much more for us and for them. So the healthy hospitals deconditioning is an important approach, and Stephen talks about that, about how we almost see somebody in the bed as opposed to seeing somebody up and about, getting his wheelchair so they can start to mobilise for him in a way that is right for him. And I think just really to thank Stephen for the generosity of his story, but also to thank the patient experience team for bringing it forward, and to thank Kerry and Troy, who I know spent time filming the story with Stephen and others. So just say thank you. Thank you, Chair.
Thank you very much, Steve. And Kerry, I normally write to people that have shared their stories, so I'll get in touch and ask you for details so that I can personally write and thank Stephen for his input today. But I was really struck listening to that. So much has been said about the importance of talk with me. It's the human things. Cherish your healthcare assistants, actually. But it took me to the first paragraph of the NHS Constitution, which says, the NHS touches our lives at times of basic human need, when care and compassion are what matter most. Really important reminder. This is what the NHS is here to do. So great to hear the learning from Stephen's experience, which I know we will want to follow through. Let us move on. And thank you again, Kerry and colleagues. Let us move on. Minutes of the meeting, it was only on the 8th of April, so it will be fresh in our memories. Any amendments to the minutes? Okay, so we'll take those as a fair record, and there are a couple of action points to be followed up, one relating to no criteria to reside as a new risk on the BAF. Eric, anything to say about that?
No, just we were going through the process of defining that risk, and we'll be presenting that back to the board to approve at the next meeting in July.
Okay, thank you. And we did also go through the board work plan and committee terms of reference and made a few comments on those at the last meeting, and work on that is also ongoing, Eric, I believe.
Yes, we need to do a bit more engagement with board colleagues just to make sure we've got all of those right, and then we'll bring that back to the board in July for approval again.
Great, thank you. Any other points people would want to pick up as matters arising? No? Okay, thank you. I know we do have some colleagues and governors with us. I don't think we have any written questions from the public, but if anybody has come with a burning thing they would like to ask of the board, now is your moment briefly. Okay, thank you. In which case we'll go on to my chair's report, which again, it's only a month since I last spoke to you about my activities, so it's quite short. But again, active across both trusts, undertaking visits and interaction with a range of colleagues. We'll just highlight the Research Star event that I attended at NBT. And this was to celebrate 40 people who had been nominated as contributing to the research effort, really in their own time, you know, doing jobs that are nothing to do with research particularly, and yet finding the time to contribute to and support the research effort. And that ranged from clinicians right through to the people in the cafe who welcome patients who are part of the cohorts forming the data for the research. So a real range of people there, and it was a real celebratory event, and really good to see so many colleagues from across the trust engaging in research in that very positive way. I've been visiting a range of partners. I'd highlight the new Health Watch chief executive. There's been a change of Health Watch arrangements in recent months with a tender going out, and we have a new provider. It was a really positive meeting. He's got a really great outlook on engagement and some really evidence-based ways of approaching the way that we work with communities. So I got the feeling that we're going to have a really positive relationship going forward with Health Watch. Also, I attended the Integrated Care Partnership Board, which was there were two items on there that were of particular interest, I think. One was the launch of a damp and fuel poverty toolkit, which is being rolled out across the system and being used by our colleagues to enable them to identify where damp and mould and fuel poverty is a factor, obviously particularly around respiratory issues, but others as well, and giving them tools that they can use for forwarding referrals to other agencies and signposting people to where they can get help. Again, the evidence from using this in London has been really impactful. So it was really interesting to hear about that and our colleagues' involvement in using that toolkit. We also talked about the ICS mental health strategy. It was quite interesting because it was relatively quiet on the interface between physical and mental health. And as you know, I'm doing a range of visits with the chair of AWP, our mental health local trust, exactly to explore those interfaces between physical and mental health in our two trusts. So a couple of weeks ago, I went to Callington Road, which is one of the main sites for AWP's services where I visited an older person's ward, an acute ward for adults of working age, and also heard about the Integrated Access Partnership, which is a partnership of AWP, the Ambulance Trust, Brisdoc and others, which is providing an urgent response as an alternative to people winding up in our EDs. There were so many things to learn about the need to progress the interface between physical and mental health. I mean, notably in the older people's ward, they need to call out the ambulance and people get conveyed to us for what might be really quite straightforward physical health conditions that could be met in other ways on the ward with a different approach. So lots to think about in that, and a further meeting and further visit coming up with the chair of AWP to UHBW this time. We've already been to services on the Southmead site. So that was a particular interest. Bristol City Council, Maria may pick this up as well. We have been having some meetings with the leader and the chief executive there, and I continue to attend the city partners meeting for Bristol on a regular basis. Nationally and regionally, I would just highlight, I had a meeting with Habib Naqvi, who is the chief executive of the NHS Race Observatory. He is going to come and visit us in June to share his thinking about the national landscape around health inequalities broadly, but also in relation to race. As it happens, he lives locally, so he has a really good insight into our local communities here in BNSSG as well. So really looking forward to that development session with the whole board in June. I think that's all I want to pick out as highlights, but very happy to take any questions, as I'm sure Sarah and Martin are on their part of the report as vice chairs. Not seeing any hands, so I'll take that as noted and for information and move on then to Maria for the Group Chief Executive's report. Over to you, Maria.
Thanks, Ingrid. Obviously, it has been a time of great change and upheaval in our system nationally. So we are responding to details that are coming out as we think about the changes around what happens at national level, regional, ICB, and again in providers, what goes, what stays, what changes. What is going to move around. We are trying to be as agile, flexible as possible. There are clearly going to be some opportunities for things to be devolved to providers, and actually with that focus on increased board accountability and oversight, and our group model, we are in a good position to pick some of these up and to deduplicate and make some of the required savings that are well publicised. So I shall keep the board updated on where we're moving with some of that. We know that the 10-year plan is still to be launched in June. There is a commitment there that there will be a performance assessment framework coming out, and that there will be an expectation that providers meet required standards, and we are part of a very large number of trusts, the majority of trusts and ICBs who have submitted a compliant plan going forward. So with spending review, with 10-year plan coming out, I think then will be the time for further discussion as we respond to some of those expectations. Performance-wise, we have had very high levels of attendance. We have been in Opal 4 a number of times, and we continue to have a large percentage of no criteria to reside patients. This is despite lots of really, really good work having gone on across our system. So this remains an area of focus. There has been some really good discussions about what we might be able to change. And as we move into a very different provider-led environment with some expectations around accountable care. I think we probably need to have a look at what this might mean. I've recently chaired Bristol Health Partners, and we made a commitment there to do a small left shifting might look like as we move activity out of hospital into the community or home environment. What are the things that are stopping us doing that? What are the lessons and principles we could learn? What are the potential funding flows or staffing issues or clinical governance concerns that we might come across that would make life difficult for us? So in the same way as we've done with single managed services under the clinical strategy, trying to pilot in a small way 1 or 2 services where we can try out. So that is something fairly new, but we'll be putting some flesh around that once we have our next meeting. And obviously members of the board will be very much involved in this work as we go forward. We have now launched cardiac services, our first single managed service. I'm sure that will come up a little bit later on in the agenda, but congratulations to everybody involved. This has been a long while coming, but great to see things in play already and actually some benefits for patients, population already coming through. Also wanted to just note that we have launched our group. We launched officially on the 28th of April. Lots of communications have gone out. So we have been able to restate our benefits case around our 4 Ps and talk about some of the main areas to prioritise in our first few months, but obviously we have a wider plan which we'll be sharing over time. We had back in February an excellent partnership event. We committed at that time to running those on at least twice yearly basis. So we will be pulling that together and letting people know when that's going to take place. A couple of other meetings that have been that I've been involved in: the NHS Impact, the National Improvement Board. There's some very exciting new training programs hopefully coming out around ClinOps, really trying to make sure that we have full training programs in place for people who wish to move into these roles. I have stood down just this month from the SWAG Cancer Alliance after a couple, 2 or 3 years actually. I think as we look at our networks, our alliances, right across the country as part of our corporate cost reduction, there is opportunity actually to realign some of the networks and the work they do in a principle of deduplicating, but also finding synergies and geographical synergies that perhaps have not been as clear as they could have been in the past. So that's a piece of work that is ongoing. And then I think just lastly, went to visit a number of places, but probably very notably the elective centre. I haven't been for a visit there in the building for about 8-9 weeks, and it has really transformed. Seeing the teams in there, the clinical teams actually getting ready to receive their first patients, getting really excited about it, the improvement trajectories, the numbers of patients we've got lined up to be seen once we start operating. It's not just a pile of bricks now, it's actually a patient resource, and really, really lovely to see the environments in there. Really fantastic space, and just wanted to say thanks. I know that we had some delays on the building programme, but thanks to Glyn teams all involved in that, and the clinical teams across both trusts for having pulled together in very short order a really good plan. So we'll be ready to start in summer this year. Thank you.
Thank you, Maria. Are there any points that anybody would like to explore further? No? Okay. Well, thank you, Maria, for that clear report, which is for information. And we will move on to the paper, which is about aligning group and trust strategic priorities. So bringing together our famed triangles around patient first. Over to you, Paula.
Thanks, Ingrid. So the board did have some discussion about how we would approach this back in February. So this is a proposal about how we will better align the group and each trust strategic priorities as set out in our patient first triangles and also our plans on a page. While we continue to work towards really full further alignment over the course of the year and achieve that by no later than Q4. So I think that approach and the reason why we're not almost approving this today is sort of a recognition that there's a bit of a transition that we want to do. The NHS 10-year plan's just been mentioned, due in June, and we want to make sure that when we look at our priorities throughout, that we're very much factoring those in. So we will formally, if you like, come back to confirm the final priorities approach. Hopefully shortly after the NHS 10-year plan is produced. We have had discussions with our senior leadership teams across both organisations about this and this kind of transition approach over the years so that we maintain the momentum that's currently behind each patient first priority projects in NBT and UHBW, but there was full support that we really want to be working once and together towards an aligned set of priorities. So that was really encouraging. Really, the group priorities fall out of the group benefits case that the board approved at the meeting last month. To note in the paper is the refresh of both sets of patient first priority projects in each trust, and that's set out in a bit more detail in Appendix A. And it's really encouraging to see continued progress that's being made when we focus our improvement efforts on a smaller number of areas, really drive that improvement right through from the board, right through all of our teams. And then we're able to move those projects on and make way for some other areas of improvement, some of which come out of things like patient stories, like we've heard today, and some which fall out of learning from national recommendations, etc. So the main point I want to really draw out before taking any comments on this is the degree of commonality, significant commonality that exists across each individual NBT UHBW priorities, and then also with our group priorities. That is unsurprising, but it's assuring. Figure 3 sets that out sort of really clearly. And I guess the key area of difference that comes across very visually when you look at that diagram is really the fact that I'd say presentationally, much more than in substance, UHBW don't have a specific strategic priority badged around commitment to our community or our populations in wording in that way. But there is significant work underway, and the substance of that runs through all of the other priorities. So that's somewhere where we definitely want to do a bit more work around making sure that we can make that alignment, because it's a really important part of our 4 Ps as a group, making that much clearer and so that people understand it. So a proposal there just for views and how we sort of hang all of this together in a coherent way in Figure 4. Welcome any feedback on that. And then, as I said, plan will be to formally approve group priorities for 25-26 following the NHS 10-year plan. Thank you.
Thank you, Paula. Thank you for all the work that's obviously gone into this. Thoughts, colleagues? Roy.
Thanks, Maria. Paula, thank you. This is all incredibly clear, and it's good to see how the new structure has sort of formed itself. I had a question about the our population side of things, and we know at least in the formation that NBT had perhaps a bit more focus on it than UHBW did. But the point is, I think it's fair to assume that the 10-year plan will have parts in there about the emphasis on prevention and population health management. It's probably a fair guess to make. So how can we go further, or can we go further on our population side of things, where it's not just being a local institution and understanding, having some inkling of where the ICS is going to go. I guess I'm challenging ourselves to say, can we commit to doing more on the population side?
Good challenge, Roy. Thank you. I'm sure we can. It's going to be a clear expectation, I agree, in the 10-year plan, and something which actually comes through in some of our joint clinical strategy as well, doesn't it?
There's about the wider determinants, etc. We know it's going to be there, and it is, and we've all agreed we want to make sure we have an overall population health view. It's can we capture that in our strategic priorities, or at least at the group level?
Sorry.
Yeah, go on, Paula. Go ahead.
Roy, I think that's a really fair point, and I think in our group benefits case, I think the population focus does come out really strongly, and it's probably the strongest articulation, if you like, of what we see our role as being, and does definitely cover that. What is our role in prevention? But I do think it'll be really key to see the kind of absolute requirements, if you like, and expectations, as well as support that come through in the 10-year plan. So what you're drawing out, I guess, is as we take that on board and bring it back for final approval, and that's an area to absolutely focus on, and indeed, may merit further conversation about a board day, as part of wider kind of system national changes.
So part of the review at the point of the 10-year plan will be to enhance that part of the profile. Okay, Sue.
Thanks, and thank you for the paper. I think it's really sensible approach, very pragmatic in terms of take this phased approach to bringing them together, and actually waiting for the NHS plan makes total sense. My question really is, as part of this, have you noticed any difference in cultures in the trusts in terms of approach and delivery of patient first? And if there is do you foresee a time when you might be bringing the teams together in terms of the supporting patient first infrastructure together to have a more unified approach to patient first? Or is that something that we'll expect in the next iteration?
So the teams have been working much more closely together, so without a shadow of a doubt. They always share learning, but the sort of degree of alignment, and as we've implemented this in both organisations, the more learning has come out of it. So the teams meet really regularly now, and neither team sort of take a position that they're going to develop the next stage of the approach without tech checking with the other. And I think absolutely, this is the patient first teams that support the deployment into our operating kind of models, if you like, are small and kind of are experts. And I think bringing them together is something that is totally about what we do once and do well, and make sure that we do bring that together. So, in the sense of I have been talking to both teams, and Lynn, I know, sort of leads patient first in NBT. So in terms of meeting the two leads together and giving them that direction to travel, they have participated in this process really, really strongly, to help us get to this point. So yeah, that will follow.
Thank you. And Sarah.
Thank you. Thanks for the paper, Paula. Really good to see this set out in such a clear way, and I support the approach. I just wanted to come back on the population health side of things. I absolutely think we have an important part to play in population health, but we need to remember that that is not what we are skilled and resourced to do, and that we need to work with partners who have that expertise and support them to do that work and draw on their knowledge, just to ensure that we get this right, because there's a real risk. Otherwise, I think that we have specialists who are not specialists in public health, but in clinical areas, for example, who will have very good ideas about what we could do, but don't have the expertise to do that on a population-wide basis. So that partnership is going to be crucial as we deliver that work, or as we look to see what we could do to deliver that going forward. Thank you.
Absolutely. It's all going to be about partnerships in that arena, isn't it? And some of the conversation we had previously about locality working as well. Mark.
I think Arabelle's
sorry,
before me.
Arabelle, sorry,
yeah.
Arabelle.
That's all right, thank you. And sensible and pragmatic were going to be my two adjectives as well. So I agree with Sue in terms of the approach. And I really like figure 4 because it really does bring together kind of all the different things we've talked about just quite simply on a page. One question I had was just about sort of benefits realization of all of the different things that we've got on here and the different commitments we've made, both in terms of what we're doing at a group level and then commitments that we make as individual trusts as well. And I just wanted to, I suppose, probe a bit on how much thinking you've given to how all these projects fit together, because I was interested in Appendix B, because it sort of starts to map some of our patient first stuff to some of our group programs and work streams. But I just wondered if there's a risk that it gets a bit blurry where we start to realize benefits and sort of claim some of those benefits, and when we're going to get ourselves into a bit of bother with some of the finances. So I just wondered how much thought you'd given to that.
It's a work in progress, Arabelle, and quite honestly, I think the approval of the group benefits case, Appendix B, sort of teases out that benefits case into the delivery programme and what particularly will be delivered in calling them this, you know, the equivalent of breakthrough objectives. But there is, I have a mock-up of a set of KPIs, but it is a very early draft that needs to be discussed with each of the executive leads, if you like, for the benefit strands, so that we start to develop that. And I think, you know, in the principles of patient first, what we want to do is not create a whole other bureaucratic structure. We want to use measures that are meaningful, measures that we already collect and map those through, but create them where it'll drive us towards that improvement in a better way. So it is fully a work in progress. We have a really robust in both organisations sort of tracking through against our current priority projects. You know, what are we aiming for? How are we going to measure it? Where are we at against that? And some of that, you know, was reported previously into the boards, but there'll be discussion and focus on that at committees as we move that through. So you'll see in the paper, one of the references is over the next sort of 6 months or so, max, working with the senior responsible officers in much more of a granular way to kind of tease out some of these issues, because something that looks the same in a title, actually underneath it, can be aiming to do fairly different things, you know, and that's what we want to do that work on. So yeah, really important that we don't sort of cloud everything and make it feel sort of much more complex, because that's not what we're about.
Right, thank you.
And Mark.
Yeah, my comments, excuse me, Chair. My comments would be, again, a really, really helpful paper. I like the language and the way it's been written. It tells it from a very kind of practical perspective as well. The two bits that came to my mind from the paper related to how through what's been described interfaces with other organisations, either locally or regionally. And secondly, would it be helpful to have a slight nod or mention to anything that WECA are involved in terms of the kind of economic or kind of growth plans? Because there's something around how the two are connected, I think. And apologies for not mentioning this earlier, Paula. It just came to mind as I was having my lunch quickly that given what's going on with WECA, the West England Combined Authority, and the local growth plans, it makes sense to make a nod there probably in terms of how those two things combine. And indeed, they are looking obviously at health determinants as an integral part of their business going forward.
So I think Mark, you're not seeing here kind of what sits underneath some of what's under some of the projects and areas. I do think the WECA kind of call, though, is something that actually came up really strongly at the strategic partnership event that we had when we were forming our group as a major stakeholder kind of engagement event. That came through really, really strongly and was one of the areas that we want to follow through on. So
Right.
I think having approved our group benefits case and now moving into delivery, I think that's where we get that opportunity coming through. But yeah, partners put that very firmly on the table, and Maria picked that one up particularly in her summary as well. That was fed back. So thanks.
Thank you, Paula. Thank you.
So just to add to that, obviously we have a new mayor in the shape of Helen Goodwin, and we had agreed with the chief executive of WECA that when the new mayor came in, Maria and I would go and meet again. We've had other meetings with them, but also we have got it timetabled in as an item for a forthcoming group board development session to think about how do we play into WECA and other partners as an anchor institution, as a force for social good and social value. So watch this space. I think there will be more that will emerge later in the summer from all of those conversations. Mark?
Yeah, sorry, Chair. I forgot to mention there's also a refreshing of the One City plan happening right now. So I think it's really important. And obviously one of the threads through this is the health and well-being thread. It's not the only one in town, but there's something around how do we weave into that conversation as well. And I'm really happy to pull through there as I sit on the One City kind of membership board, as do other people on this call. I'm sure I know Maria and yourself, Ingrid, have been there in the past as well.
Yeah, we need to join the dots of all of this. It's quite a disparate picture, isn't it? So it's going to need some pulling together. Yeah. Great. Is there anything else on this paper? Sounds like there's a lot of support.
Ingrid, if I may.
Yes, sorry. Is there a hand I've missed?
There
Apologies.
is. I know there's so many.
So I can't see you. It's Sean. Okay, hello, Sean.
Yes, yeah, and the hand is up, but I'll take it down now. Thank you. Just quickly, I thought it was a great paper, Paula. Thank you very much for that. It's nice to see it all put together, and the usefulness of it is it's actually highlighted a few gaps as well, maybe, which is always useful. But my only comment would be in Appendix A, I just wonder if we've not got patient first program in enough of those as an enabling program in enough categories, because I think if we're doing it properly, it should be sitting there in high quality care, innovate, sustainability as well. And I think that's also part and parcel of making sure that the patient first methodology becomes part of the DNA, and that's when we'll really start to get traction on this, I think.
Sean, I'd be happy to pick this up with you because I think that's a really key point. I mean, I personally see this as patient first is behind.
Yes.
The approach is behind everything we do.
Absolutely.
But I think you're drawing out where do we demonstrate our commitment to deploy it across our organisations and teams, and I know that both organisations do have those discussions and track actually where we're at in our patient first steering group. So I think it's a really fair point. It's whether it appears as these priority projects or it's just more the visibility of how we do it. But could I pick that up with you outside?
Be a pleasure, absolutely. But I just think if we make it a little bit more explicit, in order to get traction on it properly, which we certainly are, I just think it needs to be part and parcel of what we do, and it gets that understanding and how it might apply all the various different areas. So that would be really useful. But more than happy, that'd be great to do that, Paula. Thank you.
Great, thank you.
So Kelly, I think this will be the last word.
Yeah, very quickly, just to follow on from Sean's point, I think just listening to this conversation, it's just we talk about patient first. If you are externally listening to this, it sounds like this amorphous thing, and fundamentally it is the way that we deliver change. It is bottom-up led change that delivers improvement in patient care and service, and therefore improvements in efficiency and costs. And so therefore it is part of everything. It's just the way that we do things. So I know that's obvious, but I think sometimes when you're listening to this conversation, I just wanted to focus us back on that, because it feels a bit intangible, and that's fundamentally what it is, the way that I think about it anyway.
That's a great concluding comment, Kelly. Thank you. Very clearly put. Got it in a nutshell. Okay, are we happy to move to the recommendation? So we're being asked to support the proposal for alignment of the two sets of strategic priorities, noting that we'll review and refresh that after the 10-year plan is published. There are some refresh priority projects for both trusts in there, we're asked to note, and it's ongoing work. This is not destination final. So there will be ongoing work on this. Happy to support the recommendation, everyone?
Yeah.
Okay, let's move on then to the integrated quality and performance report, which I'm just flicking through my iPad, bear with me. Okay, so let's start then with the section which is around responsive. So if I could turn to Jane and Nick to take us through any highlights they wish to make on that element of the report. So Jane and Nick, over to you.
Shall I kick off, Nick?
Yeah, go on then, and then I'll follow up.
Right. Okay, fantastic. Thank you very much, Chair. I'll take the report as read. Michael, this is March, so also take the opportunity to bring us a little bit up to speed where I can. But you'll note in the report, March, a challenging operational context prevailed. But despite this, notable sustained improvements across access standards, RTT and cancer in particular, pressures across the UEC standards well rehearsed, as is the interdependency with high numbers of no criteria to reside, as Maria brought to life as well in the Chupet-Zetz report. But consequently, I think of note that actually in terms of 4-hour and 12-hour total time UEC performance standards, you'll note in March there was a significant improvement at the end of the year, and indeed that's currently being sustained. So if I do fast forward to Q1 and April, early indications, some of it's still subject to validation, but early indications are that we're sustaining good performance and forecasting forward, things are looking positive for Q1 overall. And in terms of activity, notable higher elective inpatients and day cases than planned, and more than this time last year. So again, on the activity front, a good positive position. So in summary, a positive year-end position as we forecast, so that's great. But also importantly, indications, green shoots of sustainability and continued steady incremental improvement as we move into Q1. That's all I was going to say. Thanks very much, Chair.
Okay, thank you. And we'll hear from Nick. And then I noticed on Convene, Richard's got a couple of specific questions which we'll come to. But Nick, over to you to give us the NBT position.
Yeah, I can probably try and pick up some of those questions I go through as well, because I've got them on Convene. So I think if overall, I think towards the year end, we were pretty stagnant in the UEC arena. And I think that is continuing. It is continuing through May. We are significantly challenged at the current time as well. So I think in the UEC agenda, we've effectively reviewed our UEC program, and we've also invited GERFT in to try and support us with some of our key pieces of work. These are predominantly in that UEC agenda, but I think it's also really useful to look at some of our SDEC pathways. We have some fantastic SDEC facilities. It's whether we're really utilising those to their maximum capacity through the pathway to give us our performance improvements that we require. It's a much stronger story in diagnostics as it always is. We are DMO1 compliant, which is fantastic, and we did end the year with 152 weekers. We do plan to clear those in Q1 and continue the progress that we've seen through. And the only other thing I think I want to raise before I go back to Richard's comments is around our cancer. I think we signalled to the board previously that we would see a dip for the February figures. We have had a recovery in March, and we will continue that through Q1 to meet our trajectory. So we're on track for that. We've put the mitigating actions in place, and we've also delivered the additional activity that we required. So broadly speaking, that's that. The specific questions from Richard, one was around, in the pack, it says that NBT had a 4-hour performance of 61%, and we in the main body of the text, it says 69.5. That's because we get, when it's aggregated up, we get a footprint allocation, because effectively Yate UTC is provided by Sirona, but we get their uplift, and that uplifts us to 69.5%, and that's what you will see in the national figures. The second question that Richard raised, I can see on the screen, was around the link between no criteria to reside and performance, because the performance differentiation between the two trusts. There's specific differences in the trust that mean that we get effectively the no criteria to reside position, was similar, will have a differing impact on your overall performance. So that's that. There is undoubtedly a link between no criteria to reside and our front door performance. Our biggest challenges across probably both organisations are in our admitted flow, and that is really affected by access to beds, and that is where our no criteria to reside issue falls in. I think that was the two questions that are directly related to me, and I don't know if Jane wants to come in.
It looks like she does. Yeah.
Thank you. Thanks ever so much, Nick. Yes, just back onto that last point, kind of Richard, just kind of further clarify. So in terms of UHBW, we have children's ED department. We also have an IED department. And so our year-end performance, which is 75.4%, reflects the aggregate of that performance, and that's how it's kind of measured externally. It also reflects the type 3 footprint that nationally is also reflected. If you disaggregate the adult ED department, so take Western and BRI, and you then compare kind of NBT and those adult sites, actually we're broadly operating around the same level. So that it's not as distinctly different as it appears. If you like, we kind of benefit from having the kind of aggregate of higher performance through, for example, the children's department that always performs near the kind of 90%. So that just explains that a little bit. I mean, Nick, I don't know if it's just worth us just adding, Chair, that we equally, what Nick and I are both doing in terms of is re-examining our various kind of improvement initiatives with partners externally, SWAST and so on, in terms of how we can improve the kind of front door kind of mechanisms we have for dealing with the significant pressures. Mindful that why no criteria to reside is so impactful is that it constrains onward flow out of ED, and so ED becomes overwhelmed, and then you lose all your capacity to offload your ambulances. That's the interdependence in the criteria. And we both sort of felt there would be benefits in us looking at our mutual kind of plans and where there might be opportunities to learn from each other, as well as working partnership perhaps with SWAST on some of these initiatives. So that's work to come. Thank you.
Do you want to follow up at all, Richard, or are you content?
Thank you, Ingrid, and thank you, Nick and Jane. As I said, it's the first time I've seen these, and obviously my eye is drawn to the compare and contrast and trying to understand that baseline. And as you say, Jane, where you've got 3 or 4 EDs combined together, it's true to understand, if there are any differences underneath and any particular reasons for it. So thank you for that. I know, later on the diagnostics, complaints, PT, again, drive sort of similar comparison sort of flagging in my mind. So, but thank you for those explanations. That's quite useful trying to understand from a baseline perspective where we start from.
Okay, thank you. Martin.
Yeah, if I could just quickly pick up on the point about STEC, I think it was. I just want, obviously here we get the sort of final outcome measures in a way, which is fine for the board, but is there a sort of suite of other metrics that we use that may be more indicative of things that actually help or hinder with our sort of day-to-day performance? I not being an expert, I don't know what they are, but for example, how many people are turned around in STEC and don't get admitted maybe, or these sorts of things that are more day-to-day operational. How do we make sure that every link in our chain is sort of operating to the best of its ability, notwithstanding the problem that we've got with no criteria to reside and beds in the hospital? Are those things sort of monitored routinely, I wonder, Jane?
Yeah, no, it's a really, really good point, Martin. Often when I come talk about it, and forgive me for those who've heard me say this before, but of course, if we take 4-hour or ambulance handlers, it's a measure of whole system and whole hospital performance.
So there are those things within our gift, within the department, and some of that is the interdependency with ESDEC and how we use ESDEC to deflect away from ED, but also decompress the department. So we're monitoring kind of ESDEC performance on a kind of weekly basis, as well as on a monthly basis, both because of its function in reducing the reliance on inpatient beds, so as we increase the types of kind of patients we see and turn around same day through that ESDEC department, as well as looking at the different kind of component parts of ED, from minors, in and out of hours, as well as majors. So there are opportunities that Gert will have brought this to life, as Nick was inferring. There's opportunities to improve in every pathway within ED, as well as actually recognising normal flow kind of issues. And looking at this disparity between in and out of hours, particularly in minors work streams, is one of the areas that Gert always looks at, which I think Nick alluded to. So all of these, it's made up of all those component parts. So in summary, yes, and we do monitor performance in and out of hours separately, as well as by different area in ED in terms of ESUS, majors, minors, ESDEC, and so on. And also the multiple ESDECs that we have as we're starting to grow ESDEC capability in cardiology, oncology, and so on and so forth. So certainly the UHBW.
Thank you. Any other points on this section of the report, or are we ready to move on? Okay, let's go to Steve and Deirdre then for quality, safety, effectiveness and patient experience. Over to you.
Thanks, Chair. Just 2 points to highlight, if I may. Firstly, around infection control. So C. difficile for us, NBT, is steadily moving back towards improved performance, which is good. And we've learnt from some of the work that Deirdre and colleagues have been doing at UHBW to improve our performance. So that's good. And then the second point is just looking at the perinatal quality surveillance matrix. And you'll remember there was a conversation at the last board around perinatal mortality, and there has been a spike in February and March. I'm pleased to say that April is looking significantly better. We have undertaken a deep dive, and I know Kelly, as maternity safety champion, and I have been liaising and working with the team to understand the learning in any particular issues around those cases. And we have also had a detailed conversation, which was in the report from Sarah and Kwok that came last time, just in terms of the deep dive that we've done. So April is looking better. There's still some work for us to do to conclude all of the work for learning for February and March. But I think if you look at the PQSM in total, February and March was a particularly difficult month for our maternity services. And through connections across the Southwest, that would also be reflected in other organisations as well. But for now, I'm pleased to say that April is looking significantly better than what February and March did. Thank you.
Thank you. Deirdre.
Yeah, thank you.
UHBW picture. Yeah.
Yes, thank you. So in terms of infection prevention control, really pleased to say that in UHBW, we've had no MRSA since January. Steve alluded to the fact that we've been using patient first A3 methodology to look at some improvements, continuous improvement in terms of MRSA and C. difficile. So we're really reaping the benefits of that with MRSA, particularly by introducing decolonization across the patch in a more rigorous way, following the continuous improvement. In terms of C. difficile, we finished the year on 129 cases against a trajectory, or a threshold, should I say, of 109. And this does reflect, again, alluded to by Steve, some of the emerging challenges in terms of prevalence of C. difficile locally and nationally since COVID. So we know that UKHSA has triggered a national inquiry, effectively, a national review to look at the increase, and we look forward to the outputs of that. And in terms of complaints, our response rates, so really pleased to see evidence of excellent collaboration across the patch between NBT and UHBW. And from April, we'll be adopting the complaints taxonomy used in NBT in UHBW. So in effect, at the moment, our denominator is very different. Complaints are complaints in NBT. In UHBW, we've chosen a more complicated way of, categorizing complaints, but look forward to the taxonomy allowing us the opportunity to compare and contrast and learn going forward. And just to brief the board that we'll be undertaking a deep dive into all things complaints in Quality and Outcomes Committee in June in the UHBW Quality and Outcomes Committee. And that's all I've got to raise. Thank you, Chair. Happy to take any questions.
Thank you. So I'll just check in quickly with Becky and Tim to see if they have anything to add at this point before I go to the wider board.
Just from me, Ingrid, there was another comment in convene, or a question in from Richard. I think it was relating to the disparity in the VTE risk assessment performance, Richard. I couldn't be 100% sure. That's differences in the mechanism we use to report VET risk assessment. We have at NBT, we were desperate to regain our exemplar status, which is 95%. And so we've introduced some pilots of reporting, which has increased our performance. And we are just about to share those now with our colleagues at UHBW so they can share them and hopefully see that performance become uniform. Becky may wish to comment, but I know that both organisations undertake spot audits regularly. It's part of our assurance process on the wards to check for VTE risk assessment compliance, and we regularly find those between 93 and 95%. Thank you.
Okay, thank you. And Becky, I think you wanted to come into.
Yeah, I suppose just to very briefly build on that, we're obviously rolling out electronic prescribing from next week in UHBW, and I've long said over the last number of months that we're hoping once we start to roll that out, we will see an increase in our compliance, because we'll actually be using the same system to record our risk assessment and our prescribing, which is something we don't do currently. Our VT lead did come to Quack last month and present that, and hopefully in the next couple of months, if you give us a chance to kind of get everything rolled out, and we will see that performance increase, and we're relatively confident of that. And the only other thing I was going to highlight was actually from both trusts' perspective that our SHME score, the standardised hospital level mortality indicator, is actually really good and a really positive story. And actually we're embarking on a joint mortality improvement programme where both trusts are coming together to strengthen collaboration around learning from mortality, learning from deaths, and hopefully you'll see some of that come through as we progress over the next few months, and that through our learning from death reports to board.
Good. Thank you, Becky. So any points people want to explore more? Richard, have your questions that you'd flagged been covered off okay?
Yes, it was really around DCE, which Tim sort of explained, and complaints. It's just whether there's any lessons to learn, and I think that's been explored. So that was quite useful. Thank you.
Okay, thank you. I'm not seeing other hands, so let's move on then to the people section of the paper and ask Emma and Peter to highlight anything we should be particularly aware of.
Thanks, Chair. I think it's exception reporting, and I guess that it's the same as last month, as we reported in the board meeting in April. NBT sickness absence figures have sort of plateaued at 4.6%, which is just above our trust target of 4.4%. And the board will recall a series of actions have been planned to help achieve the target, and they're summarised in the papers. The figures presented here, of course, are March figures, and we don't have April position for sickness yet. So they'll be available shortly, actually in the middle of this month. But important to note that none of the actions in the summary that we put in place in April will have been able to have any impact yet. So there's really nothing much else to report at the moment, other than that we are monitoring progress to assess the impact of those actions, and obviously we can report that back at the next board meeting as well. Thank you.
Okay, thank you, Peter. And Emma, over to you.
Yeah, thank you. I've nothing to add, Chair, because all of our metrics are either at target or better than target. So I will make no comment. Thank you.
Good position. Good position to be in. Any thoughts or questions?
Ingrid, yes, please.
Kelvin,
I'm
hearing a voice.
Yes,
sorry, Kelvin, I can't see your hand, so apologies.
No, no, it's I've got a problem with it. Once I raise it, I can take it down. So, so as per, I'm just doing it physically. Yeah, the figures are all in line. I just wonder about long-term sick for both trusts and how we are better supporting people to get support their conditions and bringing them back to work, because sometimes these figures get skewed by sort of a small number of people that are on long-term sick. So just wonder what both trusts are doing regarding that.
Yeah, thank you, Kelvin. I mean, you're right. Our total absence is the total absence. Long-term sick, we always ensure that we've got an HR advisor in UHBW that's looking after our long-term sick colleagues. As your board will be aware, we've got an occupational health service which we all utilise. So I think that we are very actively trying to support our colleagues to come back, and also trying to support them to get the adjustments that they need. We absolutely know from our staff survey data that our disabled colleagues and those with a long-term health condition, feel that there's a pressure for presenteeism. So we're doing as much as we can to support some of those changes around reasonable adjustments. UHBW, we've introduced disability leave, which is a way as well. We are trying to support our disabled colleagues in a way that doesn't feel like it's punitive as well, in terms of absence counting against people, etc. So we're just trying to be a bit more creative around how we support people particularly with long-term health conditions.
Yeah, and a lot of our provision will be very similar, NBT. I suppose, Kevin, what I'd say is that our focus is very much at the moment on the actions that we're taking around stress, anxiety and depression, and musculoskeletal, which are the two big drivers of us not being able to quite hit our target. So that's our focus at the moment. But similar to what Emma has said, that basically we manage the sort of long-term case as quite closely through our people team already. So yeah, hopefully we will see this come down as some of those actions start to play into the sickness absence. We're very aware that's one of the we'd spoken about it before as we're focusing on driving down bank and temporary staffing usage, then unavailability through sickness absence is one of the ways that we can, if we reduce that, we will bring those other things down as well. So I'm very aware of all of that.
Thank you both.
Thank you. Any other points on the people section of the report? My screen's gone a bit bananas at this moment, so somebody else will have to tell me if there are hands.
I think you're okay.
Okay, great. Thank you. Shall we move on to finance then? So Neil and Elizabeth, over to you.
Thank you. If I kick off for NBT, so this is just our month 12 position. So just to confirm, we did break even for 24-25. We ended the year with a small surplus of £30,000. So obviously, having recovered the position where we saw those challenges earlier in the year, delivering a surplus in March in order to get back to that position. The couple of other points I'd like to just note, I'll say that we delivered £22 million worth of recurrent savings behind that, which again is an increase from previous years, which is really positive. We fully utilised all of our capital that was available to us within about £2,000, which when we're talking about over £70 million, that's quite incredible. And it's also just worth noting our cash position, which we were closely monitoring during last year and into this year, was higher, but that was due to the timing of capital schemes at year end and the delivery there. So all positive news for month 12.
Great, thank you, Elizabeth. Over to Neil.
Yeah, thanks, Chair. So UHBW, if I follow in the style Elizabeth just presented, £43,000 surplus has been submitted. That's our unaudited final accounts. CIP delivery of 32.5 million, which is around 11 million higher than the year before, but still a shortfall against the 41 million target that we started the year. In terms of elective recovery fund, we ended the year 1.4 million short of a circa 208 million pound target in the plan. As I've expressed elsewhere, a great appreciation for the work across the organisation in terms of the clinical divisions and corporate functions overachieving on the control totals that we agreed in the late summer last year. I did want to mention the medical division, specialised services, Western and estates and facilities, all which ended the year in a surplus position in terms of their overall financial performance. 72 million pounds cash in the bank at the end of the year, which was 6 million higher than the plan. And we actually overspent on our capital budget. So we spent 46.8 million, so 3 million over our original capital limit, but that was acceptable to NHS England on the basis of some slippage elsewhere in the region. So we had permission to overspend to that level. So I'll stop there, Ingrid.
That's great. Thank you both very much indeed. Colleagues, thoughts and reflections on that? Or questions? I can see satisfied smiles around the screen. It's a really brilliant year-end outcome. And it's the old adage about landing, the jumbo jet on a postage stamp, isn't it? Which you have both accomplished with your teams in some style. So thank you very much indeed. Mark.
Yeah, I'm scratching my head a bit to think what question to ask, really, Ingrid. But I think with the backdrop of where things are nationally and just where things are even, within regions and other sectors, I mean, it is a great effort by colleagues to land us where we are, really, at this point in time. So, yeah, well done, I think, to all teams involved, really. Not an easy task.
Yeah, and it's not been an easy year. So we've had some bumps in the road along the way as well. So it's a very, very satisfactory outcome. Thank you. I'm not seeing other hands. Martin?
Yeah, probably just to add, because I don't think either of the FDs did that. I think this was contributing to the whole system, achieving its plan, across B and SSG, which and also sort of trusts and organisations within the NHS system as well. So great collaborative working. I think that it's been good this year to see those teams working together and making a sustainable system for the year.
Great. So thank you and congratulations to both teams for that outcome. Are we happy to move on? Or have I missed anything? No, I don't think so. Let's move on then. So we're going to take the committee upward reports, starting with the ones that have happened since our last board meeting. Starting with the UHBW Audit Committee. Anne isn't here, so I don't know if there's anybody who can speak to it or whether we just take it as read and pick up any questions with executive lead.
I was there, Ingrid, so happy to take any questions if there are.
That would be great. Thank you, Martin. Is there anything people would want to pick up from the UHBW Audit Committee report? No, it is a very clear report. So, okay, thank you. Let's move on then to Sue for the UHBW Quality and Outcomes Committee forward report.
Thanks, Chair. Yes, thank you. This is our meeting on the 29th of April. I'll take it as read. We've just gone through the IQPR and discussed the year-end operational performance. Just a few things to bring to the board's attention. First of all, I know Becky has talked about rolling out electronic prescribing, but anybody who sits in UHBW will we've discussed this for so many years. I've got to take another opportunity to say this is brilliant. Finally rolling this out in May. I've got a really detailed implementation plan, and we had a discussion around business continuity, and we were assured that this is a robust plan and it will make a significant difference to patients and to clinicians, particularly around VTE. Also, we were briefed on a visit by NHSE at Western Hospital. Again, there's a long history in terms of trainee doctors and their training. This was an overwhelmingly positive feedback from this meeting, and I think we should be congratulating the team at Western Hospital. And now all foundation trainees are rotating, and that is a brilliant position to find ourselves in. A few things really principally relating to children's services then. We heard about a bid to secure national capital funding for paediatric theatres, which is really exciting, and that will make a huge difference in terms of our RTT and ability to deliver. And again, we were also briefed on a planned CQC visit to the emergency department and Apollo ward, which are both at Bristol Children's Hospital on the 9th of May. And again, we've heard about increased investment, particularly in the ED department at Bristol Children's, and the huge impact that's had in patient experience and families who are attending that ED department. In terms of key decisions, we had a very detailed paper presented around the service provision for children with learning disabilities and autism. And it was very clear that there's a gap in commissioning, and as a result of an internal audit, the Trust has developed an improvement plan. We saw a very, very detailed improvement plan and recruiting a lead nurse for learning disabilities. But I think that because of the issue with commissioned services and for children being a gap, we have asked for a deep dive in Q4, not only to see how this post, because it's a single post, but we'll need to work in collaboration with different organisations and different parts of the trust. We want to understand how that's going to work and improve outcomes for children and their families. So we'll be doing more work in Q4 to have a deep dive. And I think what came across as part of our discussions is that there's a real need now for developing a children's strategy for the trust, but actually at system level, because there are a number of service developments, but also talking about a critical service delivery and a lot of questions, and we need to prioritise this moving forward, was the decision of the Outcomes Committee, and that was supported by the executive team. So we'd like to see some work on focusing on the development of a children's strategy with partner agencies and potentially across the ICB. Thank you.
Thank you, Sue. So, yeah, the children's learning disability thing. I mean, we know that people with learning disabilities experience some of the worst health inequalities. And so I'm grateful and glad that we're putting in place that one post. I mean, I'd question mark, is that anything like sufficient as a response? I know it's a commissioning issue and we're probably a bit plugging a gap here, but is there more of a conversation we could have?
I'm sure Deirdre will come in, but that's exactly the question that we asked. And rather than try and give you a comprehensive answer, I would imagine Deirdre and Jane will be better placed.
So I have started those conversations, as have the senior leadership try in the Children's Hospital, in terms of the liaison function, the commissioned liaison function for learning disabilities and autism for children. Of course, we are commissioned for adults, but there has been a sustained gap for our population under 18 in the acute sector. Of course, we are working in collaboration with the adults, with the adult team, to support the outcomes. And we do have specialist nurses who have expertise to provide good outcomes for children with a learning disability and autism, and have created reasonable adjustments in terms of the environment. What we need is somebody whose designated job is in creating a better strategy, more sustainably. So we're dealing with, person-centered care as the children come through our doors, but it's not sustainable as personnel change and whatever. So, but as Sue said, we will be bringing the impact of that post and potentially any further needs back to QUOC in Q4. And if I may just, Chair, while my hand is up, can I just give some feedback from the CQC visit? So we've had anecdotal feedback from CQC to say they were very, very pleased with what they saw in the Children's Hospital, in theatres, the emergency department, and in Apollo Ward. And those of you who know the Children's Hospital will know that Apollo Ward is one of our more challenged wards that deals with not just young adolescents with cancer, but also children with mental health, young adolescents with mental health needs. So positive all round in terms of the creation of the LDNA post, but also the feedback from CQC at this point.
That's good to hear, Deirdre. On the children's strategy, can we ask the executive to go away and think about how we can take that forward and come back to us with some thoughts? Obviously, it's a multi-agency thing, isn't it? And
absolutely.
Not just us. So
yeah. And I think the 3 left shifts, what we anticipate to see in the 10-year plan gives us a fantastic opportunity to get this right now.
Yeah. Okay, anything else on the quality report there? Maria?
Yeah, I'm just thinking about the work of the HCIGs, Deirdre in particular, how the overarching, and I know with Joe Walker going from North Somerset, who was overseeing the HCIG, there could be an opportunity either for us to move into that leadership space, perhaps about what an overarching children's service strategy could look like, but pulling together AWP and Sirona's input into those pathways, which I have to say isn't always as clear as you might think it could be. Could be an opportunity for us, as you say, the liaison function particularly would be something to try and clarify properly.
Couldn't agree more, Maria. I see Jane is also agreeing.
Yeah, no, if I may, Chair, and Maria, couldn't agree more. And this Thursday, I'm part of Children's HCIG, and I'm going to be supporting the Children's Hospital that are presenting the outcome from a kind of pilot about paediatric hubs. So that's about working with primary care and community partners to provide alternatives to patients coming in and looking at how we might kind of sort of develop that. So I'm going to be personally supporting the paper there with the idea that we're starting to kind of build the very thing that we're describing and Ingrid you as well. So yeah, but an excellent idea. I think it's an opportunity to further influence in that space.
Yeah, that's great. And the paediatric hubs are a great flagship success, aren't they? They're brilliant. Yeah. Okay, great. Are we happy to move on?
Can I just add to that debate if I can?
Okay.
Yeah, sorry, about the HCIGs, just to say that I think
Stu, hello.
Yeah, we just have a real opportunity right now. Well, it's not quite right now, it's in the very near future, isn't it? In regard how the HCIGs are configured and how we utilize them. As the ICB changes start to roll out, and as we have more of a unified voice and a real leadership voice in the provider space, I do think there's an opportunity for us to really look at how the HCIGs are configured and led, and what the agendas are and what the membership is, and really try and refresh some of that, and perhaps align that with how we can actually get business done. And this will be a great example of something that we could, as Maria and Joanna said, take via that mechanism in a more functional space in the future. So I just sort of do think that right in the very near future we're going to have that, I think, the right time to really start influencing that. So we should keep an eye on that as something we'll be able to pick up.
Yeah, agreed. Yeah. Anything else on that, or are we now ready to go to Finance and Digital and Estates Committee? Martin.
Yep, thanks, Ingrid. Actually, we mainly majored on digital this time. An update from finance on the year end, and an update from estates on particularly fire safety and the improvement program works that are ongoing. They did highlight, which you might have seen in there, a sort of issue around decant space, which is ever an issue to do with having to do work on wards when they are busy, but notwithstanding some possibilities with the dental hospital, still difficult to find. The main things within digital were obviously, update on electronic prescribing, as Sue's already touched on, and we reviewed on behalf of the board the digital enterprise or infrastructure replacement business case, which was a large document, circa £30 million over several years, which we were happy to approve to move to the full business case and invitation to tender stage. So great to see some progress on the digital strategy as previously approved. That's it, Ingrid.
Great, thank you. Any points to pursue on that committee upward report? Dealt with some of this earlier today, didn't we? Let's go on then to NBT, starting, Sean, with Audit and Risk Committee report. Anything to highlight? Oh, Sean? Okay, should we go to Sarah then? And I don't know what's happened to Sean.
No, I'm here.
Oh, you are here. Okay, brilliant.
Yeah, not sure what happened there, but dodgy connections. So I'll take the report as read. Just a couple of things to highlight. In terms of the internal audit progress, the head of internal audit draft opinion was one of strongly satisfactory. So that was reassuring. And obviously we've had an internal audit on the V&A, and that was good to see progress on that in a positive manner. And finally, just quickly, just to say thank you to Elizabeth and the team for getting some year-end accounts through to the auditors. And as far as we're aware, there are no issues as yet, and we don't anticipate anything. But as always, it's a phenomenal effort by the finance team to get the necessary documentation to the auditors for review at this time of year.
So thank you. Any points to raise by anybody on that? It's a year-end moment, and thank you to both audit chairs, because I know it's demanding on your time as well. Okay, NBT Quality and Outcomes Committee, Sarah.
Thank you, Ingrid. You have the report. I wanted to note that this was our first meeting where we had patient experience and performance under our umbrella. So thank you to the team for facilitating that. As Steve has mentioned, we looked in some detail at a report on the increased number of neonatal deaths and stillbirths that had occurred in the previous couple of months. The committee noted that this was extremely sad to see. There were no common themes or concerns raised from that report. And subsequently, Steve and I have had correspondence from the Chief Nursing Officer at the ICB, who is content with the process that's been followed to look into this increased number of events. And of course, we will continue to monitor that. As Steve said, the numbers for the last month appear to be less concerning. We particularly were pleased to note that there is a plan in place which is now moving forward to have patient and carer input to the work around changing services as we move into a group. And there's nothing else I wanted to highlight. Thank you.
Okay, thank you. And in fact, I think that group is due to meet for the first time before, is it in June or in July? July. So it is a real thing that is definitely happening. Okay, any points to raise on that? No? Okay, thank you for the report then, Sarah. That's all from your NBT committees, isn't it? So let's move on to the item about the UHBW use of the seals. Eric, anything to say about this?
So just for information, and we're going to need to align this report with a similar report for NBT in due course. But nothing to flag. It's just part of the arrangements we need to cover as part of our constitution.
Okay, thank you. And any other business? in which case, meeting concluded.